going to continue to grow. Let's just get started. My name is Nicole Solar. I am the Senior Vice President of Sales and Client Experience at Cenegenics. Today, I have Dr. Sean London. He is the lead radiologist with Prenuvo, as well as Dr. Rafid Fadul with Cenegenics. He is our Chief Medical Officer. So happy to have them here today. I'm just going to go ahead and pass the conversation along. We're here to talk about longevity medicine and advanced diagnostics in preventative medicine. So, Dr. London.
Yeah, thank you for the introduction. So, yeah, I'm here today to kind of give you an overview of what we're doing at Prenuvo in terms of the imaging. And, in summary, the overall concept of what we're trying to achieve here is getting a good look inside of the body as when we go to our doctors and get a physical exam. This is our way of getting the physical exam and the look inside the body. So what we're really looking for here is looking for any clinically relevant findings, which could include potential cancers, brain aneurysms, metabolic disease, such as fatty liver disease or iron overload, and any other significant degenerative changes in our spine or joints that could be affecting our daily life. So I don't know if Dr. Fadul wanted to speak on behalf of anything, or if you want me to just jump into showing some images.
Yeah, so we've got a ton of questions
All right.
that we fielded from attendees in advance. So if you don't mind, I'd love to kind of pepper you with these questions if you're good with that, Sean.
Yeah, absolutely. Let's do it.
Awesome. So first, honestly, we're in this age of advanced diagnostics. We're seeing new innovations. Feels like every week. I'd love to hear the origin story of Prenuvo.
Yeah. So Dr. Atariwala started doing this way back in, let's say, like 2009 or 2010. And I think he was doing it in his own practice. And then in around 2018 or 19 is when Prenuvo originated up in Vancouver and eventually expanded down into the United States. And it basically came about for a need for an additional type of screening in our current medical society, because ultimately, right now, we're very reactive towards everything. We wait till we have symptoms, we wait till we feel sick before we go out and seek any help. And we kind of want to flip that paradigm and make it more like actual preventative. Let's go before we have symptoms. We often find out that when we have symptoms and we go and look inside, we see that disease has probably already progressed beyond, and it kind of limits our options in terms of treatments when it's already progressed. So that's where it started, and that's what we're trying to do.
So talk to us about how the MRI actually works, just so we can all kind of level set for the lay people in the audience, and how the Prenuvo technology is different than what's the industry standard.
Yeah, so MRI is different than other imaging modalities that we have in radiology. We don't use any ionizing radiation, so ultimately we could be doing this every day and we don't know any harm that could be done from it. It's using radio waves. The other thing that's great about MRI is that this multi-parametric technique that we talk about, think of it as like different filters on a camera. So we're using different sequences to look at the tissues and give us different information about the tissues. So it gives us a really good way to characterize findings that we may not be able to characterize with other imaging modalities like CT. The other thing that we're doing is we're taking the highest yield sequences from each body part to give us the most clinically relevant information for each section. So overall, it takes about just under an hour to do the whole body. And that's for our most comprehensive exam.
Yeah, just relating to my experience, MRI of my shoulder alone was 45 minutes. So the fact that you could do the entire body in an hour is amazing. That's really awesome to hear. And, at Cenegenics, we're obviously very focused on preventive medicine, healthy aging, and longevity and performance health. A big part of that is preventive medicine and using these advanced diagnostics. So as a preventive tool, how do you think about when someone should initiate screening with Prenuvo? And talk to me about the cadence for kind of the well visits thereafter.
Yeah, so ultimately, we anybody 18 and up can come and get a screening exam. We don't really screen pediatric patients for multiple reasons, but anybody 18 and up can get an exam. And the concept here is to create that longitudinal assessment. So let's say you come in, we don't find anything significant, but now we have a valuable baseline going forward and looking for that change over time. Even if you come in and let's say we find something in the liver that doesn't look really concerning, I don't know exactly what it is, I can say, okay, well, let's come back in a year and let's see if it changed at all. So we have that kind of a assessment as opposed to going to an immediate workup and using contrast or something like that.
Got it. So there was a recent New York Times quote about there was a breast cancer oncologist who had shared that there was no evidence that supports healthy people doing whole body MRI. I'd love to hear your thoughts on it, and how do you respond on behalf of many of us who are kind of proactive about our care and otherwise healthy.
Yeah, no, I hear that argument frequently, and we're kind of building the evidence as we keep going here. I would say that the majority of the population is kind of ignored in the screening setting. We only have so many screening tests that are offered, and it tends to be towards either like very specific populations or high risk people with like genetic conditions. But then there's the rest of the population that doesn't get screened, and they have to wait until they have symptoms. So I think we have to kind of flip our mindset a little bit and look at it from a different lens.
Yeah, I know I hear that issue a lot of like, oh, well, and this, I mean, as you're aware, this kind of came up a lot with around prostate cancer and PSAs. That was a very hot button issue. And I think, the increased morbidity, mortality that we see from advanced diagnostics are actually not from the diagnostic, it's from the subsequent interventions that you do that may or may not be appropriate. And so, more information obviously is always better than less. The question is like what you do with that information. So I appreciate that insight. In that same vein, similar question kind of popped up. How does Prenuvo technology decipher between a benign abnormality and a serious finding that does require intervention?
Yeah, and so ultimately, sorry.
No, you kind of spoke a little bit to that already about like good cadence of monitoring on a go forward basis, but I'd love to hear your specific thoughts around this.
Yeah, and that's the beauty about MRI is that it gives us more information about the different types of tissues. So let's say I'm looking at a liver lesion and it has a really bright color to it. It doesn't look aggressive and it kind of follows a certain pattern in all the different sequences that we have. Can give me a good idea that, hey, this is likely a benign cyst or hemangioma, because those are common things that I see every day. Now, ultimately, if I do come across something that I'm not sure what it is, and I do think, it potentially could be a cancer, I don't really hesitate to say, hey, let's take it a little further and do an additional imaging test to get another look at it and characterize it from that standpoint. But I don't think we necessarily have to jump into a biopsy immediately. Like there's definitely a method that can be reasonable and doesn't cause harm to the patient, going forward.
Yeah, I think that prudence is that's that human piece. We always talk about nowadays like the new AI interventions that are coming into health tech, but there's this human layer that exists, and I think that's that prudence that you're describing right there, right? Not jumping into doing an immediate biopsy or God knows what else. So yeah, that's a very thoughtful approach. And actually, it's funny you mentioned this. One of the next questions was about adjunct testing when you're getting a whole body MRI. What are your thoughts around getting other additional testing or diagnostics so that the next step is in fact like very actionable?
Yeah, no, that's a great point and great question, because currently in radiology, we don't have one imaging modality to take over everything. We use one, like some of them more than others, but they're all incredibly helpful, and they can actually help characterize things that we see and give us a better picture without having to go and necessarily take a biopsy per se. So for example, like let's say I see nodules in the thyroid gland. Now on MRI, they're kind of difficult for me to characterize, but so what I would do is say, hey, consider doing a thyroid ultrasound, because we have a system set up to stratify their risk based on ultrasound characterization. So we detected it on MRI, then we jump to that next modality, ultrasound, to characterize them further. Does this need any biopsy or not? So we use everything together to make the best decision making going forward.
Do you ever think about pairing whole body MRI with serum markers?
Absolutely. Think about it all the time, and I think it's a great idea. This is not meant to be used by itself. Like, it really has to we got to use the whole picture, right? So the patient themselves, the person, do they have any signs or symptoms of anything that's concerning? Look at their blood tests and also physical exam. So you really need the whole assessment for true preventative medicine here.
Really quick, hi. We do have a question from Bob Wells. Are the MRI scans analyzed by AI, a physician technician, or both?
They are interpreted by board certified radiologists, such as myself and other colleagues that work at Prenuvo.
Yeah, and please, we encourage you to type your questions into the chat box, and we have time. We will absolutely get them answered.
Yeah, we got to keep Nicole busy. So thank you in advance for peppering her with questions. Another early question, Sean. Talk to us about a Prenuvo scan as compared to a 3T MRI.
Yeah, so ours is 1.5T. I know a lot of people say, oh, is 3T better? There's always, like, with MRI, you can't get something without giving something else up. So in general, we don't use 3T in our setting for screening. 1.5 is perfect for diagnostic in the screening setting. There are other downsides when you're using 3T, like you can get more artifacts, you generate more heat. You can go faster, but again, you can get more artifacts and you generate more heat. If I was doing single body part exams, such as like a prostate, a dedicated prostate, I would prefer a 3T, or even a joint exam, I'd prefer a 3T. But in this setting, 1.5 is perfect and gives us the information that we need.
Another audience question. So can a Prenuvo scan, and it's a little bit non-specific, but can a Prenuvo scan be used in lieu of a regularly ordered CT scan by a patient's PCP? It doesn't say what the CT is of, so obviously that influences, but just general thoughts there?
Yeah, I mean, it's kind of it's a tough question to answer directly based off of that. It can be, but again, it depends on what the indication is for the exam. So if it's a diagnostic question, we usually direct people towards a diagnostic exam, whether it's a CT or an MRI. But it's not to say that we won't get any information out of our exam.
Okay.
Another question from Karen again. What is the cost for a total body preventative MRI? Does insurance pay for this exam?
So our exams range from, we have 3 different packages ranging from $1,000 to $2,500. And currently insurance does not take this. I have heard of people getting some of it covered by insurance, but ultimately it's not covered by insurance.
So we also, Karen, just to let you know, when you come through Cenegenics, we are a partner with Prenuvo. We are also able to allocate, which is a great time of year to do so. You probably have some HSA funds or FSA hanging out, use it or lose it, absolutely applicable. So I will at the end share a slide that will have who to email, and all you have to do is I'm interested, and we'll take care of the rest for you. It's a low lift on your end.
So a few more logistical questions kind of related to this. How can our docs go about ordering the MRI through Prenuvo?
Yeah, so the best way is to just submit a referral through our physician care team, and we'll get that referral. If there's any kind of significant medical history, to include that in the referral so that the radiologist knows more patient background. But that's about all it takes.
And can you share with us the locations that are currently up and running, and then what's in the pipeline for the future?
Yeah, so currently we have Vancouver, 2 locations in California, Silicon Valley, Redwood City, and then also in LA, Dallas, Texas, Boca Raton in Florida, New York. Where else we have? We have Chicago and Minnesota. And then down in the pipeline, it looks like we're going to be in Maryland, Georgia, and so on. So we're expanding across to just provide as much as we can to anybody.
All right. Well, that so needs to include Northern Virginia. That's all I'm saying. It's my shameless plug for myself.
Which other areas are scanned? This is from Walter Bukowski. brain, chest, abdomen, and pelvis, other areas?
Yeah, so we do brain, chest, abdomen, pelvis, and then most of the extremities. We don't include the hands and elbows really. And the extremities are more like, we're looking at the joints, we're looking for, obvious arthritic changes, bone swelling, joint effusions, but we're not assessing the internal structures of the joints, which are better assessed with a dedicated exam. But we're looking at the bone marrow and the soft tissues to look for any abnormalities there. And even looking at, overall muscle mass, if there's any signs of muscle wasting. And that's where you get that longitudinal assessment over time, looking at that kind of stuff.
I think this kind of follows the same vein. We have Dr. Trevor Turner. Well, I do not believe there are any academic guidelines on this topic. What are the recommended intervals for repeat testing in a low versus intermediate versus high risk patient?
Yeah, so yeah, exactly. Currently, there are no established guidelines or recommendations. I would say in general, if I'm going through an exam and I see a lot of small findings that look low risk, I generally suggest a 12-month follow-up to say, hey, let's confirm that all of these things are still stable. And if so, you can start to extend it out. And a healthy person who comes in with a pretty benign exam, nothing really, some degenerative change in their back and nothing else going on, 2 or 3 years is totally adequate, in my opinion. But again, nothing's established at this time. So,
okay, they're coming in. So love the action. This is Joe DeLapp. What % of the time is something found that might be a life-threatening situation, I assume he meant to say, versus a non-life-threatening versus a no risk at all?
It's a great question. Currently, I don't have the exact numbers or data to give to anybody, but that is something that we are actively working on to give more data analysis of our findings for everybody.
I got a quick one for you, Sean. I'm curious, so I'm a pulmonary guy, I'm a lung guy. We deal with like Fleischner criteria all day long, right? So, and for the non-clinical folks, that's just like sizing of nodules in the chest and mass in the lungs. Are we going to get to a place where we're going to have kind of stratified guidelines pretty soon for whole body MRI, such that, as a doc, when I get this, like I know exactly what to do based on these parameters? Like, what are your thoughts around that?
Yeah, no, that's awesome. I'm so glad you brought that up because we're actually in the process of implementing something just like that. It's a risk stratification basically, and it's going to have to do with clinically significant disease and also like oncologic findings, cancerous findings, and being able to categorize them as, hey, this is highly likely benign, to a scale of, hey, this is highly suspicious, we got to do something. And so we will start to incorporate that into our reporting system so that it's very clear for everybody when they get the reports that they know how to act based on that stratification system.
I'm going to get super nerdy here, but I'm curious if like how you've paired this with liquid biopsy and the new modalities of cancer detection.
Yeah, I think it's really interesting because it seems like a lot of people that are coming in are starting to be more curious about these liquid biopsies or these, these blood tests determining if there's any kind of cancerous cells there. And if anybody ever has a positive one, like I definitely want to scan to see if we can detect, if there's anything positive. We've had a couple come through, but we have been able to correlate that test with the imaging findings. But it's kind of a newer thing, so I haven't seen a lot of it yet.
Awesome.
We're definitely getting some questions through. Here we go. So let's go to Todd Rogers. If you find a risk of cancer, what is the treatment plan before it gets worse or spreads?
So if we find something, first we have to, let's say I find something kind of moderately suspicious. The next step is either going to be for another imaging test to confirm what I'm thinking. And then it may even go to an actual biopsy. And then from there, whatever the biopsy yields will have to be discussed with an oncologist and surgeon to find out what the next best treatment plan is. Everybody is different and everything should be treated, based on that individual. So I can't say this is exactly what's going to be, the plan for every case. It really is dependent on what we find and also that individual. So.
Okay, so we have another one. This is an anonymous attendee. Can Prenuvo MRI tell us if there is a concern for NASH? So should I say NASH
NASH.
or NAFLD?
We do look for fatty liver disease. And it's actually a great test to look for it. We can look for different severities, mild, moderate, or severe. And then we can even monitor that change over time. And in fact, I've seen patients come in with severe fatty liver and with some lifestyle modifications, weight loss, exercise, decreased drinking habits. I've seen it completely reverse. So it's a great way to look inside if the blood tests aren't telling us anything.
We have another one, Joe Jalap. What happens when something quote unquote serious is found? What does Cenegenics do? Is the issue referred to my doctor or does Cenegenics handle?
So,
Yeah,
go ahead.
Yeah, so I'll answer on the Cenegenics side, but I think typically what will happen is, let's just say we were the ordering physician, Sean or whoever the radiologist is will be communicating those findings to us. We'll then immediately kind of communicate with you, and this is where what we call shared decision making kicks in, right? So we're going to kind of put our heads together and understand the individual patient's preferences. And then either we're going to kind of like quarterback it from there, or alternatively bring in whomever that you may have already in your kind of medical sphere, whether it's a PCP or oncologist or whomever, and make sure that the baton is handed off cleanly and that whatever the next steps are firmly in place before we go further, right? The last thing we want, I think this is, unfortunately, for being in medicine for more than 20 years now, I've seen it way too much where those handoffs are where things get they go awry and things get missed. So this is an area of particular focus for us, is making sure that once that data comes in, we have a very clear action plan, that we know what the next steps are, know the contingencies, et cetera. So Sean, I cut you off, but go ahead.
No, I was just I'm totally in line with you, and communication is key and so important. If we find anything significant or urgent, we're going to be communicating that to the physician and patient to make sure that they know, what the finding is and what the next best step is. So.
Yeah. We also have, can the MRI help detect what causes ITP platelet disorder?
We may see changes, but not necessarily the actual cause. So that's going to be, a further investigation with the hematologist. Okay.
Another question is, does the whole body scan detect vascular plaque?
So MRI is not really good at looking at calcification in the walls of the vessels. There are other exams like CT that can look for that. We can see changes in the brain that may be related to cardiovascular disease, but ultimately we're not good at looking at the calcification in the vessel walls. Like any screening exam, there's going to be limitations. In this particular exam, I would say the lungs, we can't see these micronodules, like, these sub 5 millimeter tiny little nodules that a lot of people have in their lungs. We can't see those things. We can't see the heart vessels well at all, because the heart's always beating and MRI hates motion. And also the intestine, the colon, we're not good at picking out polyps because people have stool content. So the polyps and the stool get mixed up and we can't tell the difference. So we're not here to replace the other screening tests that are meant to detect those areas or investigate those areas. So.
Vern Erb asked, what about kidney disease?
I mean, we can see, so I can't see kidney stones very well all the time. I can detect them if they're large enough. I would be able to see if there's any signs of obstruction in the kidneys, or if there's any atrophy of the kidneys. But otherwise, again, the blood tests are going to be really important to pair with this.
So Dr. Fadul, and maybe this is also for you, Dr. London, it sounds like this is kind of piggybacking off of the last topic about referrals. So it says Cenegenics does not perform things like surgeries then, but do you hand off to the doctor, the patient you both agree upon? So I'm assuming what Mr. Jalap means is just Cenegenics and Prenuvo hand off to a surgeon that is, I guess, elected between both of you, or maybe it's part of the patient choice. How does that typically work?
Yeah, I can grab that one. So you very commonly, let's just give you an example of like your primary care doctor who orders your CT scan of your lungs for, lung cancer monitoring. So if it's positive, that primary care doctor is not going to be the one doing the biopsy. It'll be, the pulmonologist or, in some cases, the radiologist or a thoracic surgeon. And quite similarly in this situation, if you have a finding that needs an intervention, the Cenegenics doctor will work with you as the patient to decide, okay, what's the next action plan here? Again, many of our patients actually have established kind of medical home, so to speak, already in place. So with their PCP, and they may or may not have specialists already in their network and in their sphere. So we're not going to say you only can go to this person, that person. I think this is where like shared decision making comes in, and we say, look, here are the findings. Here's what we're recommending. What are your thoughts about it? And here are some people that we think would be good in this area or near you that are strong in this area, and they can do the procedure that's potentially necessary here. But very typical to, or very, very consistent with what you would see in the primary care setting. Your PCP is not doing your biopsy, and that's a very good thing, by the way. You don't want them doing that. So similar here, like we're quarterbacking the care, making sure that the baton is handed off very smoothly and cleanly, and then an action plan is set forth.
So there's two, it's interesting. There's two questions that are kind of tied, but it's from two different people. So we'll start with this one and then we'll go to the second one. This one is from Russ Anderson. I might have missed you talking about it, but does the MRI find colon cancer?
We can see constricting masses in the colon, but really small mucosal lesions, like tiny little things that are coming off the wall, or polyps, we're really not good at detecting, and that's because people that come to us are not prepped. So like when you go for colonoscopies or even CT colonographies, which they look for polyps, they give you something to drink before you go for those exams, and it kind of flushes out your system so it's all clean, so the visibility is good. So we can see masses, but ultimately I don't want people coming in here. I don't want to see masses. So I want people to keep doing their colonoscopies as scheduled, getting those polyps before they can turn into anything bad. But in short, yes, we can see constricting masses for sure.
So again, connected but not so connected. So this is the next one, and I don't know if this is going to be in your sphere of response, but it says, could Prenuvo's growth be similar to stand-up MRIs for colonoscopy testing that was developed years ago and is now the mainstay for screening of colon cancer or colon health in adults in the U.S.?
I'm sorry, can we repeat the question?
I guess they're asking about Prenuvo's growth. Is it congruent or similar to quote unquote stand-up MRIs for colonoscopy testing that was developed years ago and now happens to be the mainstay, quote unquote mainstay, for screening of colon cancer or colon health for the adults in the US?
So what I'm hearing is, are we going to become a screening test for the colon?
It sounds to me that it's more about the growth of Prenuvo. It sounds like, again, I'm not my domain, but as stand-up MRIs for colonoscopy testing now being kind of the mainstay for that, is Prenuvo's growth plan to be
I see what you're saying.
Go-to for MRI testing? Yeah,
I mean, ultimately we want it to be established for a standard screening exam for the general population, if that answers the question.
Well, I'm sure we'll have a follow-up.
Yeah.
I hope it did. All right.
I think
the next one is, this one's actually really interesting. This is from Dr. Turner.
Nicole, can I jump in 1 second? Sorry.
Sure.
I think so Sean, I know, has some great cases. And I think having those images would be fantastic. So maybe we can jump in a few of those now, and then, sorry, Trevor, I know I just cut your question off, but maybe we can save some of those towards the back half after we review some cases.
Good.
Yeah, I can just give I'll show some example images of what we're acquiring and how we're looking at them here. So. Can you guys see my screen? Excellent. So you'll see a lot of different panels up here, and these are all different sets of images that we acquire through the body. These are basically telling us different information about the tissues, which is why we have so many different sets of images up here. But if I start up here, this is an example of a brain. This is a young female, 34 years old. And obviously this brain looks completely normal to me. I don't see any signs of, there's no mass There's no signs of scarring in the brain tissue. They look like white spots when we do see that, no strokes. The brain volume looks completely normal for age. The way I can even assess that visually is looking at this structure centrally right here. Kind of looks like a butterfly. This is where the fluid that bathes our brain and spinal cord is made. And so if I see this area enlarging, it's telling me that, you know, there's potentially tissue volume loss around here. And same thing out in the periphery here. I can see the grooves between the brain. They're nice and tight. When they get wider and wider, it's telling me that the tissue in the periphery is starting to shrink. And then we go ahead and look at the major arteries feeding the brain. This is where we're looking for aneurysms. This is a really cool set of images here. And what we're doing is looking for any kind of areas that look like balloons or outpouchings coming off the wall, because aneurysms are basically focal wall weakenings. And when they start to pouch out, their chance of, you know, as they keep getting larger and larger, their chance of actually bursting and rupturing increases. And in this case, I can rotate this around and look at it from different angles, and I don't see any signs of brain aneurysm here. And then we go ahead and look at the neck. So as I go through, we look at all the salivary glands that are by our ears. So here's a right parotid gland and left parotid gland. We have them under our tongue. So I look in the mouth to make sure there's no cancers in here. Looking under the tongue, there's glands here that look normal. And then as I kind of go through the neck, I'm looking for lymph nodes. So here's an example of a lymph node. These are all very normal looking, you know, and make sure they're not too big. In general, we get big lymph nodes from infections or inflammation that we're exposed to. And then I even go further down all the way to the base of the neck. And this is where I look at the thyroid gland. So here's the right lobe right here, and here's the left lobe. And this looks normal to me. So we can assess all the structures in the neck. And then, as I was saying, we get into the chest. Here's a picture of the chest. This is actually a full body right here, but I can zoom in and start to look at, here's the right lung right here, this black area, and here's the left lung right here, and they look nice and black. I don't see any masses in here or nodules. Centrally is the heart right here. This is the heart. Really, as I was saying earlier, it's a bit limited. All I can really tell you is, like, does it look normal size? Is there any abnormal fluid around it? And I don't see that here. But again, I can't see those vessels feeding the heart. The other areas that people were asking about is fatty liver disease and metabolic disease like iron overload. So here's the set of images where I look for fatty liver disease. And what I'm looking for here, here's the liver itself. It lives up in the right side of our abdomen. And I'm looking for the color of this liver to get darker and darker. And I don't see that happening here. So there's no signs of fatty liver disease here. And then, as I was talking about the intestine, if I go back here, so here is the colon. If I zoom in here, and this is the right side right here. And you can see all this white stuff inside. This is stool content. And here's the thin wall that kind of outlines the content. But you can imagine if there's a polyp in here, it's going to be obscured by the stool content. So which is why I can't really pick up on the polyps and why colonoscopy is still recommended in this setting. So we look at all the structures in the abdomen pelvis. And in females, we look at we do a smaller field of view, just looking at the pelvic structures, so the uterus and ovaries. So if I come centrally here, you can see this is what the uterus looks like. And in this particular person, the uterus is actually flipped backwards. I can see the endometrium really well, and it looks normal. I don't see any masses in the uterus. And as I scroll to each side, I can actually see the ovaries really well. So this is a young female, so she has a lot of follicles in here as she's supposed to. So this is the ovary itself, and all these little bright things are the follicles, which she's supposed to have. So both ovaries look normal, and I don't see any signs of ovarian cancer or any signs of uterine or endometrial cancer here. And then what I think is really cool is we get a full field of view of the spine, kind of looking for any kind of significant degenerative change that could impact our daily life. So the way we look at this is here's the spine right here. It has a nice curvature. This is a normal curve. These blocks right here are the bones that make up our spine. So these are the vertebral bodies, and in between them are these rectangles, they're discs. And here I don't see any significant degenerative changes in the spine here. If we did, we would see some disc bulging kind of sticking backwards towards this way. This is the spinal cord right here coming down from the brain, and it's surrounded by this white fluid. What is interesting in this particular spinal cord is I see this bright white stripe right here. This is called the syrinx, and basically the center portion of the spinal cord has fluid in it, and for whatever reason, this portion has actually dilated a little bit. It's actually a pretty common finding that we've been seeing in the screening setting, and all we really do is just, as long as there's no symptoms, neurologic symptoms, we just observe and make sure it doesn't change on the subsequent follow-up exams. So that's kind of the gist of, you know, what we're covering and what we're trying to detect. Are there any specific questions regarding other imaging that what people want to see?
I've got kind of a selfish question.
Yeah.
What's the smallest pulmonary mass you can pick up? Is it, you know, sub-centimeter, or how small?
Like in general, I would say 5 millimeters is the smallest one I've seen. But it's variable. Like a centimeter and up, we definitely should be detecting. Between 5 and 10 millimeters, it's a little more variable, but below that, we're not going to be seeing them.
Curious if you have any cases where, you know, someone who was presumed to be healthy or otherwise healthy, and you discovered an incidental finding that was in fact something more sinister.
Yeah, I mean, that happens. I don't have any pulled up at the exact moment, but that happens a lot, you know, with kidney tumors. And it's always interesting. It tends to be like, you know, younger people in their 40s or even 50s coming in just for the screening exam, and we see these kidney masses. They're completely asymptomatic, and we send them for the workup, and they turn out to be kidney cancers. Unfortunately, they haven't spread at all. And so resection or even other types of ablation can be curative in that sense without any chemotherapy to follow.
Yeah, I'm curious. So, you know, we call ovarian cancer like an opportunistic cancer because it can grow quite large before it starts to push on anything. So so oftentimes it's discovered very late. Have you seen Prenuvo being used in that context where cancers that typically are found late are now being found sooner, like ovarian cancer, which, you know, if not caught early, can obviously be, you know, a very poor outcome?
Yeah, exactly. And that's the thing. And that's why our visibility in the pelvis, specifically for the ovaries and fallopian tube regions, this is really great test for detecting anything that looks suspicious. And even if it's like, you know, if we see something in there and it's, you know, it's still small, but not completely benign looking, we're going to recommend follow-up, and we can do that even with, you know, an ultrasound in the interval to see if it changes at all. And if it does, then we can even go further towards another dedicated imaging exam or even surgical evaluation. So this covers a lot of those, what used to be like occult cancers and didn't present until late. Like we're able to see inside there before people present with symptoms.
Yeah, that's an absolute game changer. I mean, where was this 20 years ago, right?
Yeah, exactly. And ovarian cancer is such a great example, just because, you know, generally most of the cases that I have seen particularly in the diagnostic setting are stage 3, stage 4, with, you know, spread all throughout the abdomen and a lot of fluid buildup, you know, and it's those symptoms are so vague. And then they're often attributed to other things like, oh, you just have some indigestion, or, you know, just simple things like that, but really there's something very bad going on. What was I going to say? Oh, in this particular case, this patient has a history of breast cancer that was, you know, removed before it had spread, which is fortunate, but, you know, and detected a liver lesion here. You can see this bright kind of lobulated mass in the left lobe here of the liver, and I can characterize this here pretty confidently. I can look at it here, and it has this very, very bright color to it. And when I go to my diffusion imaging here, if I look next to it right here, this is going to give me more information about it. And it's going to tell me, is it kind of hypercellular, or is it more fluidy? And when I get down to there, I can see it right here, and it's really bright, which tells me it's having more fluid content than it is like tissue hardness, hypercellular mass. So this has the appearance of a hemangioma, which is a benign tumor that happens in our liver all the time. So I don't need to take this any further. Even with that background, I can confidently say, hey, don't worry about this, but we'll continue to follow it. So.
I've got a question from one of the patients or one of the participants here. Almost called them a patient. How long until a patient who undergoes Prenuvo will get their results?
We aim for 5 business days. If anything changes, we always inform anybody that there could be a delay or anything. But currently we've been around 3 to 5 days at the current time.
Got it. And do you have any more images, or Nicole, do you want to fire away with some more questions?
Yeah, I think we can pick up where we left off. So Dr. Turner's, we'll go there first. So this is actually interesting. Any peculiar findings you have picked up related to previous COVID infections?
We'll see sometimes occasionally some changes in the lungs, some scarring from, residual scarring from inflammation. Interesting enough, I mean, Rafid could probably speak to this more. Like the COVID infection was so interesting; it didn't cause a lot of like pleural fluid buildup or big lymph nodes. It was more just like these weird hazy opacities in the lungs. And if it was bad enough, we'd be able to detect it on the MRI. But CT is definitely going to be a better, more sensitive test for that particular disease. We did notice a lot of people getting big lymph nodes after their COVID shots. It was causing a lot of inflammation. And I'm sure the breast imaging world is well aware of that, as patients came in with unilateral enlarged lymph nodes, and they'd be concerned for a breast cancer that's spread over there. But usually it resolved after a few months at most. So.
We have Vern Erb. Does this show dementia or Alzheimer's in the brain?
So currently, when I'm looking at the brain, I'm visually looking at the brain volume in the certain areas that typically, like for Alzheimer's, it tends to affect the hippocampal folds, which are in the medial aspects of the temporal lobes. And what I'm looking for is any kind of changes in terms of the brain volume. But currently, if I'm seeing those changes on the exam, I'm thinking that there might already be some symptoms. So our goal, and I think everybody else's goal, should be to pick up on it even earlier so we can intervene. And there are definitely ways to do that, which we are looking into.
And then we just have, this is Dr. Brigazia, a personal and philosophical question. Don't you guys find it fascinating how MRIs is in spite of redirecting our hydrogen atoms in a magnetic field?
I do find it interesting.
If you know Dr. Brigazia, it's such a perfect question for him.
I know him, and this is unfortunately one of the most incredibly thoughtful physicians, and also philosophically. Like I say unfortunately because like when you're around him, I already felt dumb listening to that question. And so like he succeeded. I don't even see him, and he made me feel dumb. That was amazing.
The modality, the technique is incredible. I mean, we're basically using our own body's composition to create these images. So it's pretty fascinating. And
I think that's all the questions we have in the Q&A right now, and we're about at right where we planned on being, about 45 minutes in. We'll give it a minute for maybe anyone else to just jump on in. Is there anything else, Dr. Fadul, you wanted to comment on as it relates to Cenegenics and the relationship with Prenuvo and how we work kind of synergistically together? Anything like that to illuminate on that relationship? And then as you do that, I'm going to throw up the slide for everyone so that you know where and how to inquire.
Yeah, I mean, I'll just tell you, so obviously we're an exclusive partner with Prenuvo, and just taking a step back, so I'm relatively new to the organization, just a couple of years in, and someone just recently was asking me like why I joined, and the reason why was because I wanted to find a place that was really kind of cutting edge and really at the forefront of preventive medicine, just because selfishly, like that's what I want for myself. I want to live as long as I possibly can and live well. I'm always excited not to chase kind of like things without data and things without merit, but looking for these new interventions and these new diagnostics that are added to our armamentarium of how we look at patients. And frankly, we have this problem of a sick care system. It's not a healthcare system. And you alluded to that earlier on. Like, we're very reactive in the way we deal with our health issues. And that's a huge mistake, in my opinion, right? Like, we should be exactly the opposite. We should be at the forefront, pushing always for like advanced diagnostics. So and really like interventions early on, so that, again, Dr. Bugazi and myself, we're actually ICU doctors. A lot of that stuff, 90% of what we saw was either self-inflicted or totally preventable, right? And I would love it if there was a world where there was not as many ICU doctors needed, right? That'd be amazing. And interventions like Prenuvo are actually doing that. So I say this not wearing my Cenegenics hat, but wearing my excited human being hat, and also my burned out doctor hat from ICUs and living in the COVID era. I'm very, very excited that we're partnering with Prenuvo. I'm still waiting to get my MRI. I'm a little bit bummed I haven't gotten it yet, but yeah, I can't say enough good things about it. So and Sean, I really appreciate you taking the time to join us.
No, I appreciate you guys having me. Thank you.
We have a couple more questions in here. I'm going to cap it right here, guys. Just last three. Heard COVID fog is a lingering symptom. Can you see it in your tests, and does it differ versus how dementia looks?
We do get a lot of people coming in talking about like this long COVID or this COVID fog, and I can't say that I have seen findings that I can correlate to that specific complaint. So I would say that I don't really think there's a clear imaging finding to correlate with that, with those symptoms, unfortunately.
And then last question, I think Chris is answering Walter's question via inside the chat typing. So this is for Jessica Arthur. What does the follow-up conversation look like for the patient results? Is it as thorough as you showed the images and described today?
Yeah, so we have what's kind of unique about Prenuvo's process is that our reporting structure is really tailored so that the patient can understand, or the individual can understand what we're saying. We make patient-centric reports and try and break down all this crazy medical vernacular that we use all the time, and so that it makes sense to everybody and they can understand what our findings mean and what the next steps are. So that, and then everybody that comes to us, if they don't have a physician to go over it with it, they're offered a nurse practitioner consultation to go through the report and answer any questions that they may have regarding the findings. So, yeah.
And I think that is pretty much the question. So at this current juncture, we encourage you to reach out. Obviously, if you're looking at the screen, you'll see the email. You can put in the subject line, interested in working with Cenegenics, interested in a scan with Prenuvo. Doesn't matter, we'll get back to you. Just make sure to put your contact information. We're excited to hear from all of you. This was an awesome turnout. And thank you so much, Dr. London and Dr. Fadul. We really appreciate the time you've given today.
Thank you.
Thanks, everybody.
All right, take care.